Hello, my name is Roger Firman from the UK Association for Accessible Formats. Thank you for joining us. I'm very pleased that Sophie Randall, Director of the Patient Information Forum, is our guest. Very warm welcome, Sophie.
Thank you, Roger.
So, Sophie, you started your career as a journalist specialising in public health. Was this your plan? And if so, what fired your interest in this particular area?
Well, I suppose like lots of things, when you first start working, it was a bit of an accident. I'd certainly always wanted to be a journalist, and I took a temporary admin job at a publishing house as a kind of first step in, and I managed to persuade them eventually, after a lot of begging, to take me on as an editorial assistant. So in a way, I fell into it, and it was a magazine for environmental health officers who work in local government. But there were certainly some issues that really captured my imagination and interest really quickly. So although it was wider issues of public health, it was issues of housing and health, sort of both public sector and private sector housing, and at that point air quality, and people really starting to think about the impact that air pollution was having from cars was having on children with asthma and things like that. I mean, this is back in the 1990s. So I think that really captured my interest and started getting me really interested in issues of health inequality.
So, being a journalist, you've already mentioned that you were engaged in those particular activities. Was there anything else that you thought that you were perhaps going in a more unexpected direction just by being in the work environment and discovering things about where that was leading you?
Yeah, I think I mean, the magazine that I worked on was a weekly magazine, and it was a news magazine predominantly. So we covered everything that local government can cover. So from barking dogs to night noise patrol to health safety to major pollution incidents and major food poisoning outbreak. Mad cow disease was a big thing at the time. And I think I didn't come from a science background, and I found myself covering a lot of policy, but also talking to quite a lot of scientists and even then medics and academics. And I think what I found out then was that people are really happy to explain things that are complicated if you bother to ask them. And if you say, oh, I don't understand that, they can then find a way to explain it in a way that other people can understand more easily. And actually, I think that was a really useful lesson to bring to health information, because I think that's one of the problems that quite a lot of healthcare professionals have, and just the health system, it has its own language and its own jargon, and I've never been able to, I think because of that early training, I never had the problem of saying, oh, I don't understand that. But I think also it was a really good grounding in working with people from all backgrounds, and when you've stood in a council flat with somebody who's got cockroaches everywhere through a district heating system, and you see the impact the stress has on someone's mental health as well, it really made me understand those links between physical and mental health. We also did other work for organisations like the WHO, and we did a public health magazine for the new countries, the emerging democratic states that had come out of the former Soviet Union, and one of the big topics then was Chernobyl. And I was having these conversations with the WHO, and we were looking at children's leukemia, and they were saying, but you can't say that is caused by Chernobyl. We don't have the evidence, the real hard evidence on causality. And it was just like, but it's so obvious. You've got all these children, they're saying, look, until we've got the studies, you can't do it. So I think it kind of really taught me some hard lessons around evidence, but also sometimes that maybe we do need to take a precautionary approach when something is really clearly staring us in the face in terms of health and causality. So yeah, lots of interesting lessons that were transferable into health information.
So you were clearly very much moving into health information. And that was really the catalyst for your next step, wasn't it? Moving more into health education, more into health, that realm of activity into public health.
I would say so. I mean, I think also at that point, I think as often happens, as life changes, I'd become a mother, I had young children, so sort of the kind of slog of doing weekly magazines and late press days became a little bit more difficult, and I saw it and commuting to London, and I went for a job in a medical publishing company, and I thought, right, I'm going to do that jump now from public health to medicine. But the other thing that really interested me about that job was the opportunity to work in different formats, because that was probably at the end of the 90s. Before that, everything had been very much print based, but we started doing, the new organisation I went to work for was doing things on audio. It was using CD-ROM. It was starting to do some of the very early e-newsletters, and I just that was really fascinating to me, the opportunity to work in other formats as well as making that jump from just writing about public health to much more medical areas as well. So yeah, I think it was those two things combined that attracted me.
Mm-hmm. So as director of the Patient Information Forum, what attracted you to that position?
Well, I was already a member of PIF, so I knew the organisation really well. So once I had worked for the agency for a few years, I set up my own agency, and I did that for around 20 years. And I think one of the best things about the Patient Information Forum is it's such a broad church of people who work in different sectors, but who are all really committed to producing really quality health information. So I had, in my time running the agency, been very interested in issues around health literacy, involving users and finding out what type of information they wanted, trying to make information more accessible to other people, and also to really sort of broaden the reach and the type of people that health information both included in its development, but also its who it was then sort of targeted for, and making it more accessible. So that was really interesting to me. So I'd learned a lot from PIF. So when my interest in health inequality had kind of maintained, and so when the job came up, I thought, well, this is a great place to bring my experience of like working in this industry for 20, 30 years, and be able to make a bit of a difference in more of a sort of campaigning and national level on the availability of health information. With like-minded people. And I think that's the thing about PIF. It's a small organisation where people come together to try and promote the best practice in health information possible.
Yeah, so could you perhaps fill in some more background about what PIF is, what it does, who it represents, and its place within the sector?
Yeah, so the Patient Information Forum is 25 years old. We're a UK-based membership organisation, and we represent people involved in health information and support from all sectors. So that could be some of the massive national charities like Macmillan or Cancer Research UK, right down to some really almost tiny single-handed charities. But it also ranges from large NHS bodies like NICE to local NHS trusts or individual GPs, but also private sector members as well. So we have memberships from the pharmaceutical industry, from some big organisations like Bupa, right through to some very small tech startups that are offering very specific health information services, particularly now health information has changed so much. So really, where PIF exists is to bring all of this expertise from across the UK together and say, okay, so what is the best practice in health information? What do we need to do to make sure that everybody has access to information that they can trust, so that they can make informed decisions about their health and care, but information in a way that they can access and use and understand? And I think that's the really crucial part of what we do. So we have kind of 4 strategic pillars, and that's the quality of information. So what makes high quality information? It's evidence-based, it's user-friendly. Those are the 2 top criteria that we asked the public what they felt. That was it. But we have kind of 10 criteria for our quality mark for health information. Then we also provide a lot of training. So we have kind of a whole expertise function where we produce best practice guidance. We offer CPD accredited training to members, and we do a series of a webinar series to so people can share best practice. We also work on the integration of health information, so how people get health information and when they get it on their journeys and in what formats. And obviously that has become so diverse. I mean, health information can be anything now from a social media post right through to a large book and everything in between. And then finally, we also work on inclusion. And so that's really that bit about everybody in our vision, so that we're trying to campaign for information to be accessible based on users' needs. You know, there is no one size fits all. Whatever you're doing, you need to work with your user group to find out what their needs are and then deliver the information in the way that's appropriate for them. So that's really what PIF does in a nutshell. But it's a great organisation to work for because we do hands-on practical projects, but we are also working at a policy level, contributing to guideline development and that sort of stuff too.
Thank you, Sophie. So could you tell us, what is the PIF tick trust mark?
Well, the PIF tick trust mark is a quality mark for health information. It's a membership scheme, so people apply for the quality mark, and they have to go through quite a robust assessment of their information production process to get it. And we have 10 criteria with lots of sub-criteria that people have to demonstrate that they're meeting with their information production process to be awarded our trust mark for health information. So there are 10 as I mentioned, there's 10 criteria, and they range from evidence-based, which is obviously really crucial as the first point, but also back to those issues around having trained staff, having a written process in place so that you are actually meeting what you say you do, involving users in the production of health information, moving into some kind of co-production, thinking about how you deliver and your dissemination methods for health information, making sure that you are meeting those needs for different people in the audience. And also looking at sort of issues around health literacy, digital literacy and accessibility. So it's a very broad standard. And the final part of our standard is that we really ask people to have a continual cycle of improvement, and that they're actually looking at and evaluating whether their information is making a difference to people, because if it's not, you've got to question why you're doing it and if it's actually meeting people's needs. So that people who apply for the trust mark, and if they've gone through our assessment and action planning process, they can then put the PIF tick on their health information. And we've got 100 organisations that have now are either in, I think 76 have already been certified, and we're now up to over 100 in total that are working towards accreditation, if not already certified. The reason we introduced the scheme was that because there's obviously a huge amount of misinformation and disinformation, and we've seen this loads in COVID. So it's trying to find a way that both patients and healthcare professionals can identify trusted sources to signpost people to. So it's early days. We only launched in March 2020, but it's beginning to have quite a big impact for us now, and hopefully for people, and people will start to hear and see about the logo a little bit more. We started it because NHS England had a standard for health information called the Information Standard, which they decided to get rid of in 2019, and our members just felt this was a really bad idea, so they asked us to step into that gap. And so we kind of worked with our members to co-create the standard. We did public consultation, and then we piloted for 6 months before launching in March 2020. So it's come quite a long way. As with many things in the pandemic, things have had to develop quickly and we've had to do things differently. But we also have a website, which is www.piftick.org, where you can access that information and a list of the organisations that are accredited under the scheme.
Excellent. Obviously a lot of work in bringing anything like that to fruition, a lot of behind the scenes work, and I wish you well with the continuing success of it. Clearly, it's,
I think one of our key things is that we want people to access, be able to access those organisations that are quality marked now, so that they can have those reliable sources. So what we're trying to do is make sure that the quality mark is being used as access to other platforms. So there's something called the TRIP database that healthcare professionals use to find health information. So that will have PIV-TIC information. Health and Care Video, which provides a lot of stuff for NHS .net, is also letting content on that is PIV-TIC certified, and so is the sort of Cognitant e-health prescriptions, information prescriptions that some GP surgeries are starting to use, so that people are getting signposted straight away, particularly if they have digital health records, which more of us are beginning to get now. So again, it's thinking all the way, not just about providing this service, but how we're going to get this trusted information into people's sort of hands so that they can use it, or onto their devices so they can use it.
Yeah. Sophie, I believe you represent PIV in various ways. Can you tell us about that aspect of your work?
Yeah, I suppose that's really where we get much closer to the sort of policy kind of arena. So I represent PIV on the NICE Shared Decision Making Collaborative, and as part of the group that developed the shared decision making framework for decision support tools that NICE released last year to accompany its shared decision making guidance. So that was a really interesting piece of work, and there it does seem to be a big focus on shared decision making at the moment. So the Professional Record Standards Body, we've just been on the project group to develop their shared decision making standards. So I don't know if you're unfamiliar with the Professional Record Standards Body. It is the body that is setting standards for health and care records. So what goes into your health and care record and what comes out of it in terms of letters that come to you or anything else should be following certain standards. They're not always adopted by local NHS bodies, but that's what the PRSB does. And so to try and make shared decision making a bit more of a reality, there's a sort of standard process now that healthcare professionals should record when someone's making a major treatment decision, and part of that will be the provision of information, so that people are really looking at making informed decisions about their treatments. A lot of that is not just about content, it's also about how numbers and data are communicated to people, because we know that UK literacy and numeracy rates are quite low, and often these decisions are really complicated. So I think it's something like 40% of people struggle to use health information just based on their literacy level, but actually it goes up to 60% of people who struggle when there is kind of numeracy involved, and there is a lot of numeracy involved when you're looking at data for treatment. So we've been working with other partners to try and make sense of that and to make it easier for people to understand those numbers when they're making a decision, because I think what we've seen from a lot of the research is people will quite often sit in a consultation and they won't necessarily ask questions if they don't understand something, because most of us don't want to appear stupid. So it's that overcoming that issue so that people can make informed choices, and to make an informed choice you have to have had information that you can understand to make that decision. Otherwise, how do you come to a decision? It's not an informed choice. So that's been our kind of key element in that area. The other places we've been working with the Centre for Perioperative Care, sort of looking at how getting people fitter around and understanding risk in surgery and in that patient involvement, looking at self-care. And we've also been talking to organisations like Healthwatch about how we can influence the review of the Accessible Information Standard, which I think has now been delayed yet again. So, but it is very much about trying to influence all of these areas of policy to make sure that people do have that access to health information.
I know you've already alluded to this, but obviously this has an enormous impact in terms of the general public and the reality of all our lives, and it shows really just how much there is to do, doesn't it?
There's a huge amount to do, and I think the problem is traditionally with health information and with the best will in the world, it tends to be written with people by degrees.
Yeah.
the minimum, and it comes with a lot of complexity, and so it's hard to lose the language that you understand, you don't understand, and it's just difficult, and so it's difficult for people to unlearn what they've spent years learning, and that goes for doctors as well. But I think the problem is most people who've then been involved in user engagement in health information have also come from those backgrounds, and actually it's the people who are more likely to be ill are going to be the people who perhaps don't come from certain backgrounds. They're suffering some kind of other generalized inequality associated with poverty, who are then locked out of health information. So, or there could be other reasons why it's difficult for them to access health information, because it's not provided in a format they can use, for example. So it's actually really thinking, when we're producing information, actually, who is this information? Where is it going to make the really biggest difference? Where's it going to have the biggest impact in helping and empowering people to manage their health? And so that's where we come down to user engagement all the time. And I've just been working on a demonstration project in Nottinghamshire, where people are looking at surgery for MSK conditions, and the healthcare professionals have this very nice, well, it's not a very nice term. They think we've all become deconditioned during the pandemic, probably because we're all sitting on Zoom calls and Teams calls and not getting out and doing as much as we used to. So most of us have put on a bit of weight, or, just maybe not as fit as we were before. So now they're trying to tackle these backlogs of waiting lists. They're having to have these very difficult conversations with people about their general health. And what they're trying to do is say, in order to get you, you're going to probably have to wait 18 months for this surgery. So in the meantime, we need to try and get you sort of fitter for surgery. But these are very difficult conversations to have, and people can very, very quickly feel judged. If you're asking how much you sleep, if you're overweight, if you don't exercise. So we've just had this whole co-production panel with a group of people in Nottinghamshire, some of whom are, all of whom have got like lived experience. Some of them have had, are also quite physically disabled, which makes it much more difficult for them to do some of the kind of exercise that perhaps might be required. And we've been just trying to look at how we can get these messages across in a way that's going to resonate with people. And the first point that people have come back with is, don't make this sound like a school report about my health, because it's going to switch me off, and talk to me in a way that is not going to make me feel judged, but is going to make me feel supportive, and that actually recognise this whole issue particularly around weight, is something that is very complex, it's very emotional. So we've started off with get your mind in place first, and we've worked with this, and it's really changed the tone. It's also highlighted areas of misinformation. So nobody on this panel thought that the BMI measurement was something that was valid or evidence-based, and all thought it was complete rubbish. So we've had to think about, okay, so where doctors are using these tools, and there is a bit of misinformation, then we need to find a way to put this in a way that is going to resonate with people, that actually this is something that is evidence-based and it is used for a certain reason. So doing that user engagement has completely turned around this project. And I think this is, by working with these community groups, you're then going to get the tone right for health information as well. And I think that's so important. So I think the real challenge for the sector is to still embed this user involvement. And people think it's difficult to do. We don't think it's actually that difficult to do. It actually, fundamentally, you can dress it up in a lot of academic jargon around co-production and all of these issues, but actually fundamentally it's about going and talking to people and actually listening to them. There's no point going and talking to people and think, oh, well, doesn't fit with what we wanted to do. You actually need to listen to them and implement the changes that they're making, and you need to do it early enough in the process so that you're not sitting with a complete app or web solution and that's already ready to go, and then thinking, oh, this isn't going to work at all. So I reviewed some decision aids recently that have been done for maternity care, and they were almost at that point, and there were lots of issues in there that we felt needed unpicking quite a lot. So yeah, it just get those users involved. work out what their accessibility issues are. Now, there's a big push for digital at the moment in the NHS in particular. So a lot is particular, I think, as we go through the ICS the new ICS structures, there's going to be a bigger push to have everything recorded digitally, to have digital health records. But again, these have to be accessible to everybody. I think there's some really complex ways, I think, when we ran our webinar recently on accessible formats, I think it was the other speaker, Roger, that showed the capture thing that you have to,
yes,
for people who are blind or have got, sight difficulties or sight loss, so that you can't see the traffic lights or the thing. And everybody interpreted the number code that was said instead in a totally different way because it was so appalling. So that's totally inaccessible. And I think some of the things around the NHS app, I think those have improved now, but initially some of those things around like recording video and stuff like that was quite difficult. And I think some of that stuff is improving, but we really got to think about everyone when we're making things accessible for people. And I think, we need to think around, sort of particularly with some of the digital projects as well, about people who have got who are deaf or got hearing loss, who actually there's an assumption they can read, but that's not always the case. They might use sign language, but they might never have learnt to read phonetically, So I think it's about challenging the assumptions that we have by actually going and working out what it is that people need so that they can get involved, because I think otherwise people are excluded from having the information they need to make these decisions and make the choices that are best for them fundamentally.
Yes, absolutely. So looking at where we are today, they look to be huge areas still to be addressed, really, in the sector. And I think so much of what you've been saying just rings bells across other areas, such as those who are using easy read information and all these similar messages, putting the user at the center of what one does, talking not talking at people, talking to people. And so many of these things just resonate right across sectors, and it's just so easy to use languages that people don't, words that people just don't understand. And the assumption, as you say, about being online, the assumption is, oh well, everybody's online. Are they? And some may have no interest on being online, and then how do you reach those people? They're equally valid.
And it's interesting because we've been working with a group of GPs recently, and they were saying really having the ability to access digital services and information, digital NHS services and information on health generally, is probably as an important piece of knowledge as whether or not somebody is housebound. Because there is an assumption that we can all do virtual appointments, we can all do all of these things, but actually if you are not digitally enabled, whether that's because you don't have the skills, you don't have the connection, or you just don't have the devices or a broadband connection, all these things are quite expensive, then actually you are being excluded. And with this work we're doing in Nottingham, the panel have been really clear that it can't only be a digital solution. There has to be a paper-based solution for people who aren't digitally enabled. And I think the thing that people often forget around digital tools is the why. Why is someone going to use it? Because fundamentally, unless it's going to make something more life easier for somebody to use a digital tool, then they're probably not going to bother. So you've got to find that motivation about what it is that might make that easier for somebody.
And and that is so true of the information itself.
It is, yeah, absolutely. And I think, one of the things we hear from people over and over again is that they hate having to repeat their stories within the healthcare sector. And when you move along a pathway, I think people are under a misconception that the NHS is one massive, large, single organisation, and that data flows from one part of it about your patient history, about your record, you know, your general health, your GP record is accessible to the hospital. Well, that's simply not the case, which is why people are asked to repeat their stories over and over again, and they find it really irritating. I mean, to me personally, that is also a massive patient safety issue, because if you're just relying on somebody to report what's happened to them, that's not, you know, I don't be the first person to say my memory is not always what it should be, and particularly if I'm having to think back a couple of years.
Exactly.
So I think that having that understanding that if you do are going to download one of these digital health records, that actually you will have this information, you will have this, you can share it with whoever's involved in your care. That's really empowering for people. And it saves time as well, because you're not having to repeat your history over and over and over again. So I think it's trying to understand how these things work. And I think there's been a lot of misinformation about the data sharing in the NHS, partly because it was handled really badly, and it was, the way it was released by the government last year was so complicated that people just couldn't get their heads around what on earth was being done.
Yes.
And, you know, it's about having I mean, I don't think they did a terrific job in the pandemic either. I mean, some of the shielding letters that went out were incomprehensible. I mean, we use one of them in our training as a sort of, you know, how would you do this better? Because they were just incredibly difficult and incredibly complicated.
Yes. Claire, I'm just wondering whether we have any questions.
We do. In your view, where does the UK rank compared with other countries in this field?
I think one of the things that UK has that is really strong is, there are two things that we've got that are really strong. One is the NHS, and people love the NHS and they really trust it. And when we had the COVID pandemic, the NHS website, the hits on there went up absolutely enormously, and people were coming from outside to look at the NHS website. So I think it's as a kind of globally, it's a kind of brand that people trust. But I think the other thing that we've got in this country, which is perhaps not so well developed in some other countries, is we've got a really active charity sector by different therapy area and disease area. And I think that they are increasingly user-led, not always, but I think they are very, very focused on their users. And I know at the moment, you know, one of the things that really is driving organisations' kind of information production is really looking at what's coming through, where the questions are coming on their websites, what's coming through to their helplines, what's coming through from maybe their social media activities. So I think in this country we are quite good at actually listening to people. It's hard to say exactly how we rank elsewhere. I mean, the States have done a fantastic program for digital health records, which I think has worked really well for them. But it's hard to say. But I do think on the whole in this country there is quite a active kind of health information sector. And there's certainly, you know, and I think it's quite a professionalised health information sector as well. It's wider than just healthcare professionals, which can be the case elsewhere.
Yes, thank you, Sophie. Claire, anything else?
Yes, looking at developments since you joined PIF, what are you most pleased about?
Oh, that's an interesting one. Actually, I think one of the things that we really saw in COVID was that they really had to break down and simplify those messages and target them to individual communities. And I think that idea that one size fits all just got blown apart in the pandemic. And I think we've seen that really clearly, that you have got to think about the accessibility needs of different types of communities, sort of to access things like COVID testing, COVID vaccination. I think we've had to think about targeting communities based on cultural beliefs as well, and using trusted voices from within communities. I think we've really had to think much more about how to engage people, how to motivate them to do things, and really to get to that much more granular level about individual need. And I think that's one of the really positive things that's come out of the pandemic. I also think it has highlighted this whole issue of health inequality, that what we saw was that the people who were kind of quite often most affected were those that already had quite poor health for a range of reasons. I think that has brought a look at the wider social determinants of health, which takes me right back to where I started, about housing, about air quality, all of those things. You know, we're not all born equal, and I think it's having that wider recognition of the sort of social determinants of health, I think, is really valuable. I think what we also have seen is a kind of much wider use of different types of health information, different formats, and the more we can have the same message delivered in multiple formats in multiple ways, then the more likely it is that more people will be able to access those messages.
Very true. Sophie, thank you so much for being our guest. This is a very important area to which I think we will return sometime in the not too distant future. Thank you also to Claire for assisting with the admin of this event, and do join us in September, on September the 6th, when Gwyn McCormack will join us from Positive Eye Limited, and I know she's going to be a very interesting speaker, as indeed all our speakers are. They all have different messages, very interesting, and I'm loving this series. So thank you, and may I say on behalf of us all, goodbye from us all until next time.